Welcome everyone to our webinar this Wednesday evening here. I'm Steve Fisher. I'm the incoming president for the OKA and very honored today to have with us Dr. Jennifer Reed. As you can see on the slide here, Dr. Reed has offered to give us a wonderful presentation on exercise recommendations for atrial fibrillation. Jennifer, we're really happy to have you here today. And just for those on the webinar, Dr. Reed is a scientist and director of the Exercise Physiology and Cardiovascular Health Lab in the Division of Cardiac Prevention and Rehabilitation at the University of Ottawa Heart Institute. She's also an associate professor in the School of Epidemiology and Public Health and the Faculty of Medicine at the University of Ottawa, and an adjunct professor in the School of Human Kinetics and the Faculty of Health Sciences at the University of Ottawa. And I'm very excited to say that she's also a registered kinesiologist with the College of Kinesiologists of Ontario. And Dr. Reed, congratulations. I noticed there was a small change in your bio from assistant to associate. So I assume that means promotion and tenure recently. So thank you for taking a moment from your celebrations to be here with us today. So as you're going to learn here, Dr. Reed has a tremendous passion for research focused on the role of exercise in preventing and managing cardiovascular disease. She's especially interested in the application of exercise in the prevention and management of atrial fibrillation and developing novel exercise strategies for women with heart disease and re-examining some of the practical approaches to monitoring and prescribing exercise training in clinical populations. So Jennifer, we're very happy and honored to have you here today. Thank you for taking some time out of your schedule to share your work with us. And without further ado, we'll turn it over to you. Oh, sorry. Just one last thing for those in the audience, please use the Q&A function. So as questions arise, type those questions in, and then I'll relay those to Dr. Reed in a moderated sort of Q&A session at the end. So you're welcome to share your questions throughout, but we'll address them with Dr. Reed once she wraps up her presentation. Now, without further ado, Dr. Reed, over to you.
Great. And can everyone hear me?
Yep, sounds great.
Okay, well, thank you for such a warm and lovely welcome this evening. And it's such a pleasure and honor to be joining you all this evening to talk about an area of research that I'm very passionate about. So my goals tonight is for knowledge dissemination and for us to have a little bit of fun with regards to research that's been done and to provide you some very practical case studies for your kinesiology practice. So let's get started then. So many of you on this call will likely know that atrial fibrillation is characterized by a fast and irregular heart rhythm. In fact, in the atria, it can beat up to 250 to 300 beats per minute in the atria alone during an episode of atrial fibrillation. Now, the Canadian Cardiovascular Society defines several clinical patterns of atrial fibrillation. So when we think of atrial fibrillation, or I'll usually say AF throughout the presentation, it's not only one type. There are subtypes, in fact, 4 subtypes that we tend to group into non-permanent and permanent atrial fibrillation. So the first is paroxysmal, and that's really defined as continuous episodes lasting longer than 30 seconds, but terminating within a week, 7 days of onset. The next, as we progress through the continuum, is persistent atrial fibrillation, defined as a continuous atrial fibrillation episode lasting longer than a week, but less than a year. Continuing along, we have long-standing persistent, defined as 1 year in duration in patients in whom rhythm control management is being pursued. And then finally, in our permanent group, that is when a patient and a healthcare provider will decide not to pursue any further sinus rhythm restoration. So no procedures or further therapies, they will exist with permanent atrial fibrillation. So you may be wondering, well, what is my risk? What is the risk of my patients or my clients in my practice? And so it's actually quite substantial in that if you are over the age of 40 years, you have a 1 in 4 chance of developing atrial fibrillation at some point in your lifetime. And if we look at the number of individuals that are currently living with atrial fibrillation, this is a great slide or figure from a publication a few years ago in Circulation Research. And let me just orient you to the slide here. So here we have data pooled from a number of studies, the names which appear on the right-hand side. And then we have the prevalence of atrial fibrillation across age and years. And as you can see that the prevalence of atrial fibrillation only increases with age. And it's particularly higher in those over the age of 80 years. Now, you might ask yourself, well, what is the prevalence worldwide and specifically within Canada? So there are approximately 37 million adults living with atrial fibrillation across the globe, and approximately 450,000 of those individuals live in Canada. And so it's quite likely that you have a parent or a family member or a colleague or a friend who's currently living with atrial fibrillation. And of course, you may have patients and clients in your practice that have atrial fibrillation. And so when we say atrial fibrillation, what does that really mean in terms of symptoms? What might you expect to see with your patients and clients? So first, not perhaps surprising, is the reduction in exercise tolerance. They experience exercise intolerance, diaphoresis, excess sweating, palpitations, and of course that will come with the fast and irregular heartbeat, anxiety, dizziness, chest discomfort, acute or chronic heart failure, typically use HF to denote heart failure, fatigue, depression, and dyspnea, shortness of breath. And collectively, those symptoms contribute to reductions in quality of life, and quite substantial, I might add. Now, you may be familiar with the atrial fibrillation and stroke literature, and those with atrial fibrillation are at high risk of stroke. And that's because this chaotic, irregular rhythm causes blood to pool and clot in the left atrial appendage, shown here in this photo. And what can then happen is this blood clot can travel to the brain and then can cause a stroke, and a quite severe, debilitating aspect of having atrial fibrillation that can lead to mortality. So given the symptoms and the high risk of stroke, we of course have clinical management guidelines and have had for many, many years regarding the management and prevention of atrial fibrillation. And so we really focus on improving quality of life and reducing symptom burden. And there are a number of approaches that we can take in order to achieve these two goals. First two being rate and rhythm control. That's to slow the heart rate, and that's to try to also alleviate the irregularities in the heart rate. We also prescribed patients anticoagulation medications to reduce their risk of stroke. And then, of course, we have other procedures and therapies, one being quite familiar is cardioversion, where we essentially shock the patient back into sinus rhythm. Quite common in the emergency room to see this happen. And the other is ablation, catheter ablation. And that's when we go in and actually ablate the tissue around the area of the heart that's causing these irregular electrical impulses. So from a medical point of view, these are the medications and procedures that are used to typically manage atrial fibrillation. But despite these therapies and tools, about 80% of patients with this condition experience continuing disabling symptoms. And so that's where the exercise piece, the kinesiology piece, can come into play, because there has now and recently been a large focus on the role of exercise, physical activity, in managing atrial fibrillation. And so this slide, I'm going to take you through several systematic reviews that have been published over the last few years, which have tried to synthesize the growing literature in this area. And so we begin with a bit of a walk in history, really. We start with the Canadian Journal of Cardiology in 2013, when a group of investigators and clinicians from the East Coast first published the first systematic review examining the health benefits of exercise rehabilitation in persons living with atrial fibrillation. And then my colleagues and I, at the same time, 2013, Canadian Journal of Cardiology, we were focused on looking at the chronic effects in individuals with permanent atrial fibrillation. And then a few years after that came a Cochrane review, a highly reputable process for examining the state of literature on a particular topic. And a Cochrane review, systematic review, was published on exercise-based cardiac rehab for adults with atrial fibrillation. And then again, my colleagues and I were invited to contribute to a special issue in the Canadian Journal of Cardiology, and really an update, because the evidence and the research being done in the area was continuing to accumulate, which begged for updated systematic reviews and meta-analyses to be conducted. So we purchased one, we published one. Yes, oftentimes publishing does involve purchasing, but that is a discussion certainly for another day. And so for here, we have the publication of the effects of cardiac rehabilitation in patients with atrial fibrillation. And then last, but certainly not least, the most recent being a systematic review and meta-analysis looking at the effects of cardiac rehabilitation, and that's the incorporation of a systematic review or randomized and non-randomized trials within this systematic review. So the literature has continued to grow, and as a result, we've had a number of systematic reviews trying to synthesize and make sense of the evidence to date. And so what have these systematic reviews shown? Well, I've attempted to summarize the findings of these reviews. And so we see from these reviews and the evidence to date that with regular exercise training, chronic exercise training, we see improvements in peak aerobic power, which is your VO2 peak or VO2 max, cardiorespiratory fitness, functional capacity, which is typically or can be measured by a 6-minute walk test, how fast you can walk or far you can walk in 6 minutes, strength, power, improvements in activities of daily living, improvement of quality of life, cardiac function, and improvements in symptom burden. So very promising and supportive for patients with atrial fibrillation who struggle with a myriad of issues. So in response to these reviews, my colleagues and I published this practice article in the Canadian Medical Association Journal. And for those of you on the call, I likely don't have to re-explain, exercise principles and FIT standing for frequency, intensity, time, and type. But we endeavored to put together a practical article for clinicians, healthcare providers, regarding exercise and atrial fibrillation. And so our FIT principle suggests that those with atrial fibrillation should exercise at least 3 days a week, most days of the week, at a moderate intensity of heart rates of 90 to 115 beats per minute. And that can get a bit tricky, of course, with patients with atrial fibrillation, given their fast and irregular heart rate. So it may not always be the best guiding measure for assessing exercise intensity. And so we could look at 64 to 76% of peak oxygen consumption if you have access to cardiopulmonary exercise testing results. And if not, we can use the well-established, valid, free practical talk test, which is if you can carry a comfortable conversation, you're likely exercising at moderate intensity, and it becomes quite challenging to hold a comfortable conversation that we're clearly into the vigorous intensity. So that tool can be used across all practices when prescribing exercise and physical activity. Individuals should also aim to exercise at least 60 minutes per session. But of course, we want to ensure that those that have been previously physically inactive or have poor exercise tolerance would build to 60 minutes, so 10, 20, 30 minutes over time. And then we would recommend that activities use large muscle groups that incorporate, walking, jogging, rowing, and cycling. So with the beginning, the rise of the literature in this area, it's so great to see that the Canadian Cardiovascular Society and the European Society of Cardiology have published recent management guidelines for those with atrial fibrillation, and they've focused some of their efforts on exercise and physical activity within these very large guidelines that are typically published every few years. And so we'll begin with the European Society of Cardiology. And I know your practice would specifically be in Ontario or Canada, but I just wanted to give you a flavor of what's being done on an international level, on European level, in terms of the guidelines regarding exercise and atrial fibrillation. So here you can see at the bottom of the slide, there's this red arrow, and it says that there's class 2A level support, that physical activity should be considered to help prevent atrial fibrillation incidence or recurrence, so the onset or recurrence, with the exception of excessive endurance exercise, which may promote atrial fibrillation. And in our talks today, our discussions are not going to focus on the endurance training aspect. We're going to focus more on just regular physical activity that likely would be achieved by most Canadian adults, kind of the typical general population, and those that you may see in your practice. But then we looked at the Canadian guidelines for the management of AFib. So this is new, 2020. Both these guidelines were published. The Canadian guidelines for the management of atrial fibrillation are the first in the world to provide very specific exercise recommendations. And so in the bottom corner here, you'll see that the guidelines recommend moderate intensity aerobic exercise, at least 30 minutes a day, at least 5 days a week, so a target of at least 200 minutes per week. Resistance training exercise 2 to 3 days a week, and then flexibility exercises at least 10 minutes per day, at least 2 days a week for those at least 65 years of age. So again, the first in the world to provide very specific exercise targets. Within this clinical guidelines document, they also have suggested an integrative AF care plan. And what you might see if you look on the left hand, or sorry, the right hand side, you'll see exercise physiology. So the field is really starting to move. Now we have clinical guidelines endorsed by the Canadian Cardiovascular Society that is recommending that exercise physiology, so kinesiology, exercise physiology, be incorporated into the AF care plan of patients. So if you've not previously worked with patients with atrial fibrillation, you may now find new referrals or patients coming your way as a result of some of these new clinical care guidelines. And if you haven't yet, well, then hopefully the discussions this afternoon or this evening will provide some insight in terms of how to manage and prescribe for these patients. So I wanted to highlight this letter to the editor that my colleagues and I published shortly after these guidelines, because while I say it is really encouraging to see these guidelines published and specific exercise targets, we scratched our head a bit and thought, where did these at least 200 minutes come from, and the very specific recommendations regarding resistance training and flexibility, when that's a bit more specific than the Canadian physical activity guidelines in general. And also they differ from the general physical activity guidelines for all patients with cardiovascular disease. So we published this letter to the editor, just probing to say, we're not sure where these exact minutes or threshold came from. It's encouraging certainly to see these targets, but of all the literature that's been published to date, we can't quite see clearly where these specific targets come from. But nonetheless, certainly encouraging, and we wanted to applaud the group, the Canadian Cardiovascular Society, for incorporating these exercise targets into their most recent clinical care guidelines. So what we did in this letter is actually, we looked at all of the systematic reviews and the original articles included in the reviews, and we put together this summary figure within our letter to the editor. And so when we compared regular chronic exercise training, we could see that for an average of 8 to 16 weeks, exercise volume of 60 to 225 minutes weekly, these are the findings that we were able to synthesize. And so exercise for at least those number of weeks and a volume target of at least 60 to 225 minutes resulted in improvements in cardiorespiratory fitness, functional capacity as measured by a 6-minute walk test, improvements in left ventricular ejection fraction, cardiac function, which is key for those with cardiovascular conditions, and improvements in quality of life. And we also saw reductions in resting heart rate and maximal heart rate, again important for this patient population, a reduction in time spent in atrial fibrillation, and symptom burden, all goals of our care guidelines for patients with atrial fibrillation. We also saw a reduction in cardiovascular disease risk factors, but these were certainly conflicting. And when I indicate cardiovascular disease risk factors, I'm referring to hypertension, I'm referring to high blood glucose concentrations, perhaps elevated body mass index. So those results were conflicting, but based on our review of the literature, these were the durations of weeks and volume with regards to exercise minutes that we observed from the literature. So now it's really important to understand what may be driving some of these improvements that we've seen in the literature. And so this is a wonderful article published by Elliott and colleagues in 2016 in a very reputable journal known as Circulation, one of the higher impact journals in the field. And so again, they have focused here and provided a nice synthesis on kind of regular exercise training, aerobic exercise training, at least 3 to 5 days a week at an intensity below very vigorous at a time duration of 120 to 200 minutes per week, and including aerobic exercise and resistance training. And what they published in their particular review was that there were certainly short-term and long-term benefits of this regular aerobic exercise. And they speculated on the potential mechanisms by which exercise may improve AF burden, and that being reversed atrial remodeling, weight loss, improved blood pressure control, improved glycemic control, reduced inflammation, and improved autonomic tone. And the point today is not to get into these potential mechanisms, but just to make you aware that these are some of the potential mechanisms that may explain why, short-term less than 6 months and long-term more than 4 years of regular exercise may contribute to the improved AF burden that patients with atrial fibrillation experience. Now, it may not be surprising to those on the call. I'm not sure of all your specific disciplines and area of work, but given you've signed up for a webinar on exercise training in atrial fibrillation, and you've joined OK here, I'm assuming that it's not going to come to any surprise to you that if we remove an exercise training intervention, and that's what this particular publication research study performed, they looked at the effects of 3 months of detraining. So the removal, in this case, of a cardiac rehabilitation program, which was exercise-based. And following the removal of this program, they observed significant reductions in physical fitness as measured by total watts or highest watts achieved on a cycloergometer test, and also reductions in quality of life. So remove the intervention, remove the exercise, and we see loss of some of the gains, of course, that would have occurred with exercise. So most of my presentation this evening so far is really focused on continuous, moderate to vigorous exercise training. And I wanted to spend just a few minutes discussing high intensity interval training. You've likely read about the benefits of high intensity interval training in media newsletters, research publications, discussion with your colleagues. And so you might be very familiar with the concept that it's a form of exercise in where we alternate intense periods of exercise with low intensity of recovery periods, less intense recovery periods. So this idea of work hard, recover, work hard, recover. And when we work hard at these intense periods, they're for brief periods of time. And this is certainly not a new concept. The concept, the idea of interval training dates back to the time of the ancient Greeks, where athletes used HIIT to improve their fitness for track and team sports. But the application within chronic disease populations, those with atrial fibrillation, those with cardiovascular disease, is certainly, we'll say, newer and more novel within the past few years. And this is a particular HIIT protocol that is very common throughout the literature. We call it the Norwegian protocol because it was developed by a Norwegian group. And the idea here is that you warm up for a few minutes. You then engage in 4 minutes of high intensity exercise at 85 to 95% of heart rate peak. And then you recover for 3 minutes at a lower intensity, 60 to 70% of heart rate peak. And you would repeat this high intensity interval with a recovery for 4 blocks for a total of 25 minutes of conditioning, and then finish with a 3 to 5 minute cool down at a lower intensity. And so the literature and researchers across Canada and certainly the globe have looked at, well, when we go head to head with HIIT and with MIT, moderate intensity continuous exercise training, forgive me, we use all these acronyms within our field and likely many, many other fields. But what the literature has shown, and in several systematic reviews, is that when we compare HIIT to MIT, we see greater improvements in VO2 peak power, resting and submaximal heart rates, blood pressure, left ventricular filling speed and diastolic relaxation, high density lipoprotein and triglycerides, fasting glucose concentrations, mental health, quality of life, and motivation. Certainly, a very encouraging list to see when we're considering exercise paradigms for our patients and clients with chronic diseases, and in this case, atrial fibrillation. And as a result, I wanted to spotlight this particular article that was published by Malmo and colleagues at a Norwegian group, published in the Journal of Circulation. And they looked specifically at the impact of this Norwegian protocol, interval training, on the burden of atrial fibrillation in patients with non-permanent atrial fibrillation. So if you remember back to the beginning of the presentation where I went through the 4 categories, these would be patients in the first 3 categories, the non-permanent group. And so what they did is patients with atrial fibrillation, non-permanent atrial fibrillation, exercised 3 days a week using their Norwegian protocol for 12 weeks. 3 days a week for 12 weeks. And in the end, what they observed when they compared their exercise group to a control group, and a control group being those who just maintained their normal daily physical activities, we saw a reduction in the time spent in atrial fibrillation. And so in this figure here, if you look to the exercise box, you'll see mean change minus 3.3, and that indicates a mean reduction of 3.3% time spent in atrial fibrillation. And so, you know, is that statistically significant? In the study it was. Is it clinically significant? You know, we've kind of debated and discussed this over the few years since this has been published, but given that patients with atrial fibrillation continue to suffer with their symptoms despite pharmacotherapies and surgeries and procedures, this is clinically relevant because it's a reduction in time spent in atrial fibrillation, and it's the time in atrial fibrillation that is quite disabling for patients. And so I'm actually pleased to share with you, you're actually the first group I'm sharing this with outside of our investigative team, but we've recently finished a randomized control trial looking at the impact of HIIT versus exercise-based cardiac rehab in patients with persistent and permanent atrial fibrillation. And this publication, the results are scheduled to be published on October 31st. Halloween. So trick or treat, hopefully perhaps a treat for those that are interested in this area. But the results of our randomized control trial, where we screened several hundred patients, consented 94 and randomized 86. So like the flip of a coin, half of the patients were randomized to exercise-based cardiac rehab, our MIT group, and the other half were randomized to HIIT. And they completed 2 sessions a week for 12 weeks with measurements at baseline and follow-up. And so all of these results will be available on the 31st in JAMA Network Open. This is the open access version of JAMA, so it is free. You can find it online. If anyone is interested in reading it and can't find it, feel free to send Oka or myself an email. I would happily share this with you. But our goal was to make this open access so accessible to all exercise professionals and cardiovascular professionals across the globe regarding looking at different exercise training interventions in this population. And a superstar in my research group, Salvidal Amela, who is a PhD student, also recently published a case series looking at the acute effects of interval training in patients with atrial fibrillation, permanent atrial fibrillation. And I will highlight that this is a case study, meaning there are few patients included. This is not a large sample. It cannot be generalized to thousands and thousands of adults across the globe, but we've spent so much time focusing on the chronic effects of exercise training over the years that we haven't spent a lot of time looking at the acute responses. And for those of you on the call that see patients and clients, those individuals standing in front of you, that N of 1 may have some fears regarding exercise training and high intensity interval training, or continuous forms of exercise training. So this case study, published in the European Society of Cardiology, the European Heart Journal, their case report series. And so in this, we've included the data from these 4 male patients, different ages, each one approximately in a different decade. And we've provided some very detailed information regarding the heart rate responses, the ratings of perceived exertion responses, and blood pressure in response to our HIIT protocol, which was a bit different. 30 seconds on, 30 seconds off. They repeated this for 8 blocks, took a break, and then repeated again. But if you are curious to look at some of this detail regarding an individual response, then this is available. We also made this open access, free of charge. So if you Google the title, you will hopefully find it. And again, if not, feel free to contact me or Oka, and I'm happy to share all of these resources. And I'm assuming the presentation will also be available. So we've now spent some time discussing continuous exercise training and high intensity interval training and acute exercise training. And so I've presented some of the data showing you the benefits, the potential benefits of regular exercise training in patients with, all forms of atrial fibrillation. But now we need to look to, well, are these patients active? And when we look across Canada, we see that approximately 15 to 20% are actually meeting our Canadian physical activity guidelines. And so, very few adults, general healthy adults, individuals are meeting our Canadian physical activity guidelines. So what happens if we look at our patients with atrial fibrillation? And so I pulled this publication, which was just published by my research team this year and was led by a postdoctoral fellow who is now faculty at Deakin University in Australia. And so this observational cohort study, we were able to recruit 619 patients in the Champlain-Lynn, which is the eastern area of Ontario, Champlain Local Health Integration Network. And so with all forms, all clinical patterns of atrial fibrillation, we assess their physical activity levels using a self-report validated physical activity questionnaire, the IPAC, which is the International Physical Activity Questionnaire. Is certainly not without limitations, self-report data, so keep that in mind. These weren't device measures of physical activity, but what we did find in this first study to look at the Canadian population was that 56% were not meeting the Canadian physical activity guidelines, and 54% were unsure of the physical activity recommendations. So certainly some room for work there. Now I'm going to give you a bit more of detailed data here, but I'm going to orient you to the green box on this figure. And so this is the overall data. This publication is also open access, freely available. So if you're interested to dig into the data a bit more, it is available to you. And so what we've presented here is the data regarding walking, moderate intensity, vigorous intensity, total moderate to vigorous intensity physical activity, and sitting time, a measure of sedentary behavior. And so the data is presented in a median format, given it's not normally distributed data, and typically physical activity data is not normally distributed, but we have provided the values here for the cohort and also the values according to the AFib subtypes, the clinical conditions. There are no differences between groups, but we have provided the descriptive data nonetheless to show you. We wanted to go a bit beyond just assessing physical activity levels, and I think this is where some of the really interesting data comes in, because when you have a patient and client in front of you, you may provide the recommendations, but it's really good to understand a bit behind the scenes some of the exercise psychology involved in exercise and physical activity. And so we decided to look at, and this is just a very small snippet of the data presented in the article, but we looked at the knowledge and values regarding physical activity. And so we asked patients in this questionnaire format, has a healthcare professional spoken to you about engaging in physical activity for your AFib? And 59% reported no. I'll mention here that these were all patients recruited throughout the Champlain-Lynn, but they also were patients that came through the University of Ottawa Heart Institute, which is one of the largest cardiovascular institutes in Canada. So a very cardiovascular focused institute with a large cardiac rehabilitation program. And so even when we asked patients that have come through this institute, 59% are reporting that a healthcare professional has not spoken to them about their atrial fibrillation. When we ask them if physical activity can help manage other conditions, because often patients with atrial fibrillation have coronary artery disease, elevated levels of body mass, and certainly other chronic diseases. So 81% responded that yes, they do believe that physical activity can help manage their conditions. When we asked them, do you think physical activity is dangerous for your atrial fibrillation? 66% reported no. And when we asked if they think that physical activity should be part of your management plan, 72% reported yes. So you may find these clients and patients within your practice, and this may give you some insight into what they may perceive regarding exercise and physical activity. So I've kind of tried to give you a lot of information, essentially a snapshot of the entire field regarding exercise training and atrial fibrillation over the last few years. And so I've obviously spent some time focusing on the continuous form, the interval training, the acute, and some of the recent work we've done looking at, the levels of physical activity. So I thought I would end kind of the latter half of the talk on some case studies, hoping that this would provide you some practical information as exercise professionals. So just to start, a very brief review. Again, I'm certain this talk will be available afterwards, and some of this information I can certainly provide if you would like copies of it. But I just want to orient you to this table. And so here, the point of this table is to show you intensities. How do we define light, moderate, vigorous, or near maximal intensity? And so depending on what is available to you in your practice or what information is coming to you with your clients and patients, this provides the ranges for percent VO2 max, percent heart rate max, percent heart rate reserve when we incorporate resting heart rate values, or VO2 reserve when we incorporate resting VO2 values, the rating of perceived exertion scale, the talk test, one of my favorites, and MET level ranges. So if you're not sure, which intensity and what tool you can use, this table provides a synopsis, a summary of what is available in the literature. And so here is our Borg rating of perceived exertion. Bonus points for those at the end of the talk that can explain why the Borg scale goes from 6 to 20. It was developed in 1982 and a very common, practical, feasible, essentially free tool to assess ratings of perceived exertion, how hard somebody is working. And so let's start, we've got two case studies to cover. So let's start with Mrs. B. She is a 76-year-old female, sex being sex assigned at birth. So we've pulled that from her medical record. And as you can see, she has quite an interesting medical history. Persistent atrial fibrillation. She had a catheter ablation in 2015. The next day, she was back in atrial fibrillation, so failed ablation. She also failed cardioversion later. In 2016, she was intolerant to amiodarone, which is a medication typically used to manage the irregular heart rhythm. She has coronary artery disease. She experienced a STEMI, a myocardial infarction, with ST elevation in 2014. Also presents with hypertension, gout, gastrointestinal bleed, obstructive sleep apnea, very common in patients with AFib. So this may be a perfect example of a client or patient that you may see and provide exercise prescription for. So I've tried to give you a more complicated case to begin with in terms of medical history. These patients typically take a number of medications. The ones ending in OL are beta blockers, and that's really important to understand because beta blockers can blunt the heart rate responses. So lower heart rates at rest and perhaps lower heart rates during exercise. And so that may factor into your exercise prescription plan. And currently, Ms. B is not performing any purposeful exercise. So we performed a cardiopulmonary exercise test, and here are the results from the test. I'll walk you through the results if you're not familiar with typical CPET outputs, but this was a CPET performed on a cycler ergometer. So we have peak workload watts, 85, peak heart rate of 155, normal blood pressure response, peak oxygen uptake of 11.7, and peak METs of 3.3. So you may look at this data and go, these values seem a little low for peak oxygen uptake and peak METs. Well, they certainly are. This is a patient who is poor exercise tolerance. The test only lasted 4 minutes and 5 seconds. This is actual data from our lab. And as you may know, that typically we like to see these tests within 8 to 12 minutes to effectively assess aerobic exercise capacity. So this was not a particularly great test, but a test that certainly Mrs. B could undertake. From her ECG, no evidence of inducible reversible ischemia, so we proceed along. And so if Mrs. B were to present to you after her exercise-based cardiac rehabilitation program, she was seeking the services of a kinesiologist, exercise professional, here's an example of what you could provide. These are certainly not written in stone. These are individualized per client, per patient. This is simply an example of how I might approach it. And so I would recommend exercise 5 to 7 days a week. This would be based on the literature. We would certainly build up to 5 to 7 days given that Ms. B was not previously physically active, a heart rate of 120 to 146 beats per minute, which is about 40 to 85% of heart rate reserve. That aligns with our light to moderate intensity in the previous slide. And again, heart rate may not be the best tool, so you may choose ratings of perceived exertion and recommending 12 to 16, moderate effort. If perhaps you wanted to sign Mrs. B up for high intensity interval training or a bike-based workout, I've provided a range in watts, the specific values that accompanied her CPET results, but really what's important is what's in the brackets. It's the range, because that's giving you an indication of the intensity. We would recommend exercise sessions be 30 to 60 minutes. Again, building, very, very key to build. Most of our patients with atrial fibrillation, right, begin with 10, 20 minutes, and that can be quite challenging. So you may build over time. All depends on the person in front of you. And we might recommend cycling, jogging, or elliptical. And then for our case 2, Mr. S, who is 67 years of age, permanent atrial fibrillation, no other medical histories of note to discuss today. Medications include a multivitamin and Eliquis, which is used, which is anticoagulant to reduce stroke risk. Not surprising given AFib. Currently walks for up to 60 minutes twice a week. And so after performing his CPET, he was able to achieve a peak workload of 200 watts, heart rate of 230, hypertensive response, which is what we expect to see with cardiopulmonary exercise test to a maximal volitional exhaustion, peak oxygen uptake of 33 mLs per kg per minute, peak METs of 9, exercise duration 9 minutes and 20 seconds. There we have it within the 8 to 12 minute time range that we're looking for. No symptoms reported during the test, and negative for evidence of reversible ischemia. And so on we go to the exercise prescription. And again, this will depend on the patient in front of you. For this particular patient, this is a prescription that you may provide 5 to 7 days per week, typical most days. Based on their absolute heart rate values, I would again prescribe 40 to 85% of heart rate reserve, and that aligns with 139 to 207 beats per minute. A workload, again, if you're wanting to endorse cycling or perhaps doing a bit of interval training, you certainly could do so. And I will point out that in our trials that I presented to you early, these were very deconditioned patients that were able to engage in our fairly aggressive high intensity interval training protocols. So not for everyone, but we've certainly done it. And of course, have now published the data for anyone that might like to explore that option of exercise training. Last but certainly not least, RPE 12 to 16, standard for moderate intensity or just verging on vigorous. 30 to 60 minutes building over time. And again, you could prescribe the same type of exercise depending on what your clients may have available to them, whether they have a gym membership, whether they have equipment at home, whether they simply want to walk in their neighborhood. So customizing the program to their needs and interests is always recommended. So those are our 2 exercise prescriptions. And so with a few minutes left for my talk, and I want to ensure a good time for Q&A, I'm going to try to summarize all of this information that I have presented here tonight into a few points to kind of drill this down for you. So hopefully this all makes sense. So first and foremost, patients with atrial fibrillation, most of them report ongoing symptoms despite the medications, the pharmacotherapies, and procedures that are available. So not uncommon for these patients to seek support for additional healthcare needs, and certainly they may come to kinesiologists and exercise professionals for those adjunct therapies. Growing research, again, all of those systematic reviews that we presented really as a result of the growing area of research shows that exercise training improves several physical and mental health outcomes based on the literature to date. Certainly could change over time, but based on literature to date, that's what we can present as a summary point. Most patients with atrial fibrillation are not likely regularly physical activity or active. I presented some Canadian data. There's some excellent data across Europe showing similar findings. And so we're seeing most of these patients are not physically active, and that really aligns with their poor exercise tolerance that they typically present with. We should encourage them to accumulate at least 200 minutes per week. Again, we scratch our head a bit at the 200 minutes, but certainly encouraging, and we want to move forward. So 200 minutes per week, somewhat similar to Canadian Physical Activity Guidelines, World Health Organization guidelines. If you don't have a CPET or any fancy equipment available to you, not a problem. You can use the talk test for exercise intensity prescription, validated, and there are many research articles on its practical use. HIIT may be promising. You may certainly have clients interested in HIIT, or you yourselves may be interested in HIIT if you know a family friend or anyone with atrial fibrillation. So some more work is certainly needed, but initial data is encouraging. And cross-disciplinary research, I can't stress that enough within the field of kinesiology, those that are experts in more the psychology side, ergonomics, there's a range of areas within kinesiology. And so insights from other professionals within our field are certainly helpful for trying to improve the physical activity levels of patients with atrial fibrillation. Okay, and so with that, I'm going to end there to just ensure that there's adequate time for questions. I'll leave you with a photo of the Heart Institute, which I mentioned. We recently celebrated 45 years, and this is our new designed Heart Institute, which is located in Ottawa, which is where I am. I've provided my email address and also my Twitter handle, where I'm fairly active. And so if you want to reach out, there's some contact information there.
Excellent. Dr. Reid, on behalf of the Ontario Kinesiology Association, I just want to say again, thank you so much for providing us with a wonderful talk this evening. I particularly like the case study examples. I think that's a really helpful way to sort of visualize, and interpret how some of that evidence is being applied in practice. So very wonderful. As you were speaking, a number of the attendees, and we can see lots of applause for you coming in there in the
well, thank you.
I can't see,
so obviously I can't see everyone, but thank you. It's lovely to be connecting with all of you this evening.
So as we were going along, there were a number of questions have kind of funneled in, so I'll try to sort of play some of those back to you and see if you can expand a little bit. So the first question that came in was related to high intensity interval training, and I think the question kind of came in just as you were diving into it, but could you share a little bit more on the high intensity interval training side? So maybe to preface this a little bit more, when you're doing high intensity interval training, what are the modes of what are the exercises that you're using? How are you packaging this together? Are there contraindications that you're watching for, and maybe speaking at a little deeper level on that?
Yeah, no, those are great questions. And I certainly didn't have time to drill into that during the presentation, but this is a great opportunity. So most of the work that we've done with high intensity interval training and patients with atrial fibrillation, we have first done a cardiopulmonary exercise test on a cyclo ergometer. And the reason for choosing that modality comes down to their heart rate, their unique heart rate conditions. And so with a cyclo ergometer, we are able to test their peak or maximal workload. And so we are focusing less on the heart rate piece and on the workload element. So that is what we use for exercise prescription. So the opportunity trial that I mentioned, all of those HIIT sessions were done on a cyclo ergometer. And so that is the modality of that particular RCT and has been the modality for other RCTs. Because typically, if you were to perform a treadmill test, you would certainly have a peak or maximal heart rate and peak blood pressures. But then to prescribe based on heart rate, you certainly can do it, and others have done it. But some just prefer, given the unique heart rate control issues, especially if there's quite a bit of variability in beat to beat, then the cyclo ergometer may be another option. So that is selecting a cyclo ergometer as a modality and then prescribing based on workload. But I have other trials where we're doing high intensity interval training, and we're doing the same Norwegian protocol, but using a dance-based format. So our patients are wearing heart rate monitors, and we're prescribing based on heart rate. And so certainly the HIIT protocol is not limited to one modality. It could be on an elliptical, cyclo ergometer, treadmill with jogging and running, or walking intervals, or dance-based, moving, Zumba, all forms of interval training. And so you're not restricted to modality. Really depends on the patient in front of you. And if their heart rate is relatively regular, given the medications they're taking, then you certainly could use heart rate-based exercise prescription methods.
Yeah, just a kind of a follow-up to that then, and this is going to maybe perhaps a more naive question, but would it be feasible or plausible to blend in exercises that have more of a resistant element? So maybe wrapping a HIIT training framework around, squats or some body weight squats or something like that would, again, some challenges with managing heart rate, but would that be acceptable as well?
100%. It just really hasn't been done. And so with the Canadian Cardiovascular Society guidelines, they're the first to provide specific targets for patients with AF with resistance training, but very few of the prior trials have actually included resistance training. But I mean, you would know, and others on the call, resistance training has been around for decades and decades and decades, and there's so much research supporting regular resistance training. If we look at our Canadian Physical Activity Guidelines, World Health Organization guidelines, we should be recommending, 2 resistance training, strength training sessions per week. So certainly those could be done in a HIIT format. I think what I would suggest is you can use the HIIT as a paradigm of how to set up the intensity, but the modality, there's certainly lots of flexibility and doesn't need to be isolated to continuous aerobic exercise, and certainly can be resistance training. And for the fact that a lot of these adults are older adults, if you look at the prevalence, it increases with age, where falls and fractures become really important. And so building in resistance training is even more important as we age, and certainly could form the basis for an interval training protocol. So excellent question and thought.
Great. So changing tack a little bit here, you spoke a little bit about some of in the case studies, I think you kind of touched on this, but are there differences in the exercise prescription for, let's say, a patient presenting with atrial fibrillation who just had I might get this word wrong, an ablation? I'm not in this space, I apologize, but an ablation versus somebody that's, just treating with medications?
In terms of how you would approach the exercise prescription?
Correct, yeah. So would you approach it differently, I think, in terms of maybe how you're setting thresholds and tolerance levels?
So typically what we've done is if we have a patient that's undergoing ablation, so they're going in and they're burning the tissue. So this is a procedure where they ablate, they burn the tissue, trying to rectify these irregular electrical impulses. Typically, we know within a few days, not a few weeks, but patients revert back to AFib if the procedure is not successful. So we see in the case study with the example, they reverted back to sinus rhythm within a few days. So if the procedure is not successful, then you know quite quickly, and then you can move on with your exercise training prescription. Cardioversion is very similar. If they shock the patient and it's not successful within that day or so, then again, you're assuming atrial fibrillation, and you continue on prescribing for a patient with atrial fibrillation. Most individuals will be taking medications. And so it's quite common you're going to have a patient in front of you who is taking a medication to blunt their heart rate response, lower their heart rate. And often these patients feel really fatigued and slow, hard to kind of get moving. So it's kind of part and parcel for the clinical management is, one, I would expect them to be taking a number of medications. And those medications are designed to help control the heart rate, both the speed and the irregularities. So that can be factored into your prescription. And with regards to procedures, as long as patients are feeling okay to begin their program, if the procedures haven't been successful, they remain in atrial fibrillation, and you can continue very quickly following those procedures with regular exercise training.
Excellent. I think that's that's great. That's really helpful. A couple questions have come in, just thinking about the overall prevalence of atrial fibrillation. And are we collectively seeing an increase? Any thoughts on if we are, why? Is it maybe perhaps related to things like, more people are tracking heart rates and sensitive to what's going on with their body, or thoughts on that?
Oh, those are two questions really, and two really good questions. So all the things I didn't get to talk about, but I'm glad you're asking them. So one, is the prevalence of atrial fibrillation increasing across the globe? Absolutely. And so there are a few reasons for that. The two main ones are, we have an aging population. And so given that atrial fibrillation, the risk increases with age, and we see atrial fibrillation more often in older adults, with an aging population, there are going to be more and more cases of atrial fibrillation. So we do call it really, we say it's an epidemic, because the cases are certainly increasing, the incidence and prevalence. So age is driving, the aging population is driving an increase in prevalence. The other piece that's driving an increase in the prevalence is the cardiovascular disease risk factors. So poor physical activity levels, rising rates of high blood pressure, unmanaged blood glucose concentrations, hyperlipidemia, increases in body mass index, all those traditional cardiovascular risk factors, they all contribute to the development and progression of atrial fibrillation. So if you have a client or a patient who's physically inactive, who's hypertensive, elevated cholesterol concentrations, elevated body mass index, and stress, that also factors into some of the inflammation piece. If you have an individual with those risk factors, it's more likely they will develop atrial fibrillation. And so we have a combination of a rise in cardiovascular disease risk factors. Most of them can be managed quite well, prevention and management with regular physical activity, but we have just really failed our World Health Organization physical activity report. So we've got low levels of physical activity across the globe, and we have an increase in cardiovascular disease risk factors, and we have an aging population. So when you combine all of those 3 points, yes, it's much more likely you're going to see individuals with atrial fibrillation.
And then the secondary piece there was around sort of the fact that folks are maybe tracking their heart rates a little bit more, and maybe you could speak to the wearable sensor element, I suppose.
All of these points are so good. I just get excited about talking about atrial fibrillation. So those are great questions, because there are a number of devices now on the market. So the Apple Watch, right? There are a number of devices that are now available that have built-in ECGs that use sensors that can detect the irregularities in heart rate. And so that technology is certainly emerging. It's becoming more common with smart wearable devices that you can track your heart rate, and certainly those with ECG capabilities either can provide continuous ECG assessment, or you can do intermittent ECG recordings. And there's been a lot of work looking at whether these devices, there's one called the Alive Core. You can connect it to your smartphone, and with your fingers, you can take an ECG reading with this Alive Core device connected to your smartphone, and it can tell you whether you're in normal sinus rhythm or if you're within atrial fibrillation. So this medical device can be floating around on your smartphone, and you can use it to, one, if you're a patient with AFib, use it to confirm an episode of AFib, or it has been used to identify those that didn't know that they had AFib. And that's very common, that not everyone who has atrial fibrillation will be symptomatic. I presented to you some of the symptoms that occur, and they're quite disabling, but not everyone knows that they have atrial fibrillation and may have some of these symptoms, but not equate that to having atrial fibrillation. And so these devices can be used to certainly identify new cases and incidents of atrial fibrillation. And then you can see the path, and if we identify new cases with some of these technologies, we can help actually act quicker with regards to stroke prevention.
Yeah, which hopefully is fantastic, and an ounce of prevention is always worth so much more.
Yeah.
So I know we're getting to the end of time here. Just one more question while we have you, Dr. Reid, and it's, I think, a really interesting question that we often grapple with is the exercise psychology side of this. So in your studies looking at HIIT training and other modalities, have you taken any, or have you obtained any measures on sort of the psychological variables that might be related to different training modalities? I know there's some evidence in HIIT that people do it, but they don't love it, but they like that it's short. Like could you speak to the psychological piece a little bit before we close out today?
Yeah. I will say that's one area that we haven't really done enough of. We've focused a lot more on the physical. What I've certainly tried to do in a lot of my trials is look at both the physical and mental, but usually when we've looked at the mental, it's more aligned with looking at anxiety and depression and quality of life, not so much the enjoyment or some of the other exercise psychology pieces, where I'm certainly not an expert in that area. I hope to not use the terms inappropriately, but some of the affect and enjoyment pieces, we haven't done it to date, but we have actually, we're conducting a virtual only interval training program with women with heart disease. And so our interventions delivered virtual over Zoom platform, and we're watching patients through webcams and collecting all of their data connected to heart rate monitors through private chats. And so in that study, we actually are collecting some of those exercise psychology pieces. We have an expert in the team who studies that area, Dr. Jennifer Brunet at the University of Ottawa. So we are certainly collaborating with those that spend a bit more time in that area, because we recognize the reasons why someone may engage in exercise, or how much they enjoy or don't enjoy a HIIT session versus a MIT session, or resistance training or flexibility, is so key in driving, hopefully driving regular participation in physical activity. So you'll have to kind of stay tuned for results of that trial. Or if you know individuals who are female who have heart disease, send them our way, because we would love to increase enrollment.
Fantastic. Well, it sounds like that's a good opportunity for us to invite you back in the future to do a little bit of a follow-up on some of those findings. With that, Dr. Reid, thank you so much. Again, on behalf of the OKA and everybody in attendance here, really appreciate you taking some time out today. And congratulations on all the wonderful work you've done. I think this is exceptional and great to see engagement, both as a researcher, but wearing that RKIN hat and like I said, touching on the practical elements, the case study elements. For those on the call, Jay Reid at ottawaheart.ca if you have follow-up questions, at Dr. Jennifer Reid as well if you'd like to follow on social media. And again, congratulations. Thank you so much for joining us. I really appreciated it.
Well, and thank you, and the attendees. I appreciate the floating emojis coming in, so that's lovely to see. It was well received.
Excellent. Thank you very much. And everyone, again, thanks for joining us this evening. Have a wonderful evening, and we'll see you all again soon.